everyone by the team of neurosurgery. We initially invite Colonel Professor P.S. Bhandari sir from Haldane to give a lesson on exploration of brachial plexus. Thank you.
Good morning to your professor, Dr. Anita, Dr. Prabhat, Professor Plastic Surgery, and I'm not familiar with other teaching faculty. I'm so sorry, and dear students. So this morning, at first, I'll show some videos, so that before we go to the workshop, we will have some idea how we do the various procedures in brachial plexus surgery. So these are edited videos, but I think you'll be able to understand the basic steps. Volume, can you reduce? This is the first, step in brachial plexus surgery. Incision you have seen. The aim is to first reach to the spinal accessory nerve, which is the main donor nerve, and we check the functionality also by stimulation. Extrajugular vein, sometimes you might have to sacrifice it, but we can save it also. Now we reach towards the omohyoid. This muscle is omohyoid. This is an important landmark to the suprascapular nerve. So we divide it. The suprascapular nerve runs parallel to this omohyoid muscle. Here is the suprascapular nerve. So this step is very important because in almost all cases of brachial plexus injury, we have to do this nerve transfer, spinal accessory to suprascapular. It is not working. That is the area where the trunks are there. We are stimulating, but there is no response. Now we take the length of this, we go little distally. This is the communicating branch to the spinal accessory nerve, which comes from the cervical plexus. We have to preserve that, and we should go distally as much as possible to get the length of the spinal accessory nerve, so that the anastomosis can be done without tension. This is the distal part of spinal accessory nerve. We should preserve the proximal branches to the trapezius. Distal part. Here we will divide it. So communicating branch, we have gone distal to that. Now we will divide the suprascapular nerve proximally, close to the upper trunk. So we have got good length of both the donor and the recipient nerve. The extra tissue, connective tissue can be removed. The scar segment of the nerve can be removed. We have to reach to the healthy fascicles, bleeding fascicles, and then we can do the coaptation with 9-0 nylon suture. 2 sutures followed by glue coaptation. We can augment this with the fibrin glue. So this is spinal accessory to suprascapular nerve transfer. After that we can close the incision, putting a drain subcutaneous in the subcutaneous planes.
This is catgut. Suture is catgut.
This is chromic this is monocryl. These days we don't use catgut. Even chromic catgut is also more or less obsolete now. Monocryl gives it's a very less reactive suture, monofilament suture, so chances of infection are very less. It gets absorbed later on. And skin closure you 40 nylon suture. Now this is how we do the anterior exploration of plexus. See the incision. This skin flap is raised. We should include the platysma. Again, first step is to isolate the spinal accessory now. Now this patient had infraclavicular injury. So most of the supraclavicular plexus is normal. So we will be able to see the various roots of the plexus. Overhead. Transverse cervical vessels, they should be protected. Now we are in the region of the upper trunk. So this is one of the root C5. This picture we will not see always, because in most of the cases the roots, the trunks are injured. We only find the scar tissue in the supraclavicular dissection. As I said, this happened to be a case of infraclavicular injury. That's why we see the different parts of the supraclavicular plexus. This is the supraclavicular scapular now. So we can see C5, C6, C7 roots. This is the spinal accessory, the C5, C6, the following upper trunk, and C7. Now we come to the posterior dissection. Posterior approach to the spinal accessory to suprascapular now. The patient is in the lateral position. We give an incision over the scapular spine, divide the trapezius, and underneath we try to find out the spinal accessory now. This is done when we suspect there is distal injury to the suprascapular nerve, which sometimes happens with the fractures in the scapula, in the clavicle. So once we have done the isolation of spinal accessory, we go towards the medial side, towards the suprascapular notch. Here the vessels, suprascapular vessels are being clipped. This is the nerve, proximal to the notch. Suprascapular. Suprascapular nerve. So now we can divide the now proximally, the spinal axis now distally, and we can do the coaptation. Here only the glue was used, not the suture, but it is always safe to put one suture or two sutures and then augment with the fibrin glue. And we can close the skin incision. Now, this is so-called Somsek transfer. Transfer of the long head triceps branch of radial nerve to the anterior branch of axial nerve for the deltoid reinnervation. It is recommended in partial injury, C5, C6 injury, where the radial nerve is normal but deltoid is paralyzed. Deltoid is innervated by C5. So, this is the incision on the upper lateral arm. With this incision, we will go to the two spaces, triangular space and quadrangular space. The radial nerve is in the triangular space and axial nerve is in the quadrangular space. The radial nerve will follow the branch to the long head of triceps, which is the donor nerve. And in the quadrangular space, we'll isolate the axillary nerve and then its branch to the anterior part of deltoid, that is the anterior division of axillary nerve. So the dissection is between the triceps, long head and the deltoid. So we will go to the triangular space first. This is the radial nerve, we can see. So we'll isolate first radial nerve and then we'll look for its branch to the long head of triceps. Radial nerve. Long head triceps branch. This is the triceps, long head. So we'll divide here. So this is our donor nerve. I have done some modification to this procedure which I'll be just showing to you. This is the teres major. Here is the quadrangular space above the teres major and we'll look for the axillary nerve in this space, deltoid. So this transfer was described by Dr. Somsek from Bangkok. That's why this is called known as Somsek transfer. He's basically hand surgeon, orthopedic surgeon. I spent about a month with him to learn this technique. This is a very important technique in partial injuries for getting the deltoid function, abduction. So this is the distal deltoid and we look for now the anterior branch and posterior branch. So we'll use this branch as a recipient now. This is the posterior branch, the quadrangular space. So we'll go a little proximal to gain the length of the anterior branch. It will be divided here. So this is the triceps, dividing into two branches, long head triceps branch, donor nerve. We'll cut from here close to the muscle. This is that axillary nerve anterior branch, the recipient nerve. recipient now for deltoid, and this is the donor now. So we can do the again coaptation. Now coming to so-called overland transfer, again it was described by a hand surgeon, orthopedic surgeon from France. Very good now transfer in restoration of elbow flexion in partial injuries, C5, C6. Again, here the donor nerve is either ulnar or median nerve because they are supplied by C7, C8, T1 mainly, and recipient musculocutaneous branches to the biceps and brachialis. So with this incision between the biceps and the triceps, we reach to the musculocutaneous nerve. Here is the biceps. The first step is to isolate the musculocutaneous nerve and its branches to the biceps and brachialis. This is the branch to biceps. Musculocutaneous. Here will be the branch to brachialis. So recipient now, brachialis branch. This muscle is brachialis. This is the biceps. Brachialis branch. Distally, the musculocutaneous nerve continues as cutaneous nerve, supplies the skin on the radial border of forearm. Brachialis. Now we'll look for now the donor nerve, that is the median and ulnar nerve. One fascicle from ulnar nerve will go to the biceps, one fascicle from median nerve will go to the brachialis branch. Dissecting the biceps branch little proximal and will divide here. Donor distal, recipient proximal division. So if we see this is the cutaneous segment, and if we see two branches going to the brachialis, it is the distal segment. Looking for now ulnar nerve. So we'll take a fascicle of ulnar nerve for the biceps branch. This is the median now, sorry. Now we'll look for ulnar now. So here is the ulnar nerve. If you take just one fascicle out of these two now, it is not going to affect the function of the donor nerve. So this is the ulnar nerve. When the transfer was described initially by the Oberlein, he said he used only one fascicle from ulnar to biceps. This distal transfer was not done to brachialis. So now we'll divide the recipient nerve proximally, biceps branch. This is the biceps branch. All dissection is done under loop magnification. Ulnar donor nerve. So randomly one fascicle is taken from the ulnar nerve, which requires minimal interfascicular dissection. When the transfer was initially described by Oberlein, he insisted that we should take the fascicle which supplies the flexor carpi ulnaris. But what I found was that whichever fascicle you take, stimulation of the fascicle produces the same kind of movements in the wrist and the fingers, that is ulnar flexion and finger flexion. So in my practice I use fascicle which requires minimal interfascicular dissection without going too much for the nerve stimulation, and then transfer it to the biceps branch. In the same Journal of Hand Surgery, I published this article also, where the Oberlein has first published his paper. And these days I think most of the surgeons are following the method which I have described in performing this bifascicular nerve transfer. Median nerve. Median nerve fascicle generally given to the brachialis branch. There should be very, very careful handling of the nerves with micro instruments. One should resist taking more fascicles because it will downgrade the function of the donor nerve. So this is the fascicle of the median nerve which will be used as a donor nerve for the brachialis branch. So they can be coopted together. Now coming to a very popular and very commonly performed nerve transfer in total brachial plexus injuries, because we don't have here the median ulnar nerve functioning or deltoid, radial nerve working. So we take extra plexal nerves, and the intercostal nerves are generally available to us. We take 3 intercostal nerves, 3rd, 4th and 5th. This is the region of the pectoralis major flap. And these intercostal nerves are transferred to the musculocutaneous nerve for elbow flexion. This is the recipient nerve, musculocutaneous. In this case, there was distal injury to the lateral cord, means in the region of lateral cord and medial cord. Now, this is the rib, 3rd rib. We give an incision over the rib, do the periosteal dissection, lift the rib up and then divide the periosteum. We have to gain a good length of the intercostal nerve so that it reaches to the musculocutaneous nerve without any tension. So dividing the periosteum now, posterior periosteum, and then we look for the intercostal nerve. You encounter small vessels there, they should be carefully ligated with, not ligated, they should be cauterized with very small vessels. So we should not give thermal damage to the intercostal nerve. That's why we are putting the saline, we are taking all of care to avoid the thermal damage. This is posterior part. The nerve will be divided from here. This is the motor component. Similarly, we divide third, fourth, and fifth nerve. 3 nerves. Three nerves. Here is the musculocutaneous, the recipient nerve. So now these are very thin nerves, and putting even 9-0 suture becomes difficult. That suture also induces some fibrotic reaction. So I use this splint and weld technique in coaptation of intercostal to musculocutaneous nerve, so that no suture is passed directly through the intercostal nerve. The suture passes through the glue and the epineurium of the musculocutaneous nerve. The axons grow by the process of chemotaxis from intercostal to musculocutaneous. So the edges are freshened. Now we can see the 3 intercostal now. Now we'll put 2 sutures, 6 and 12, 12 o'clock, epineurium, musculocutaneous, and through the glue, not through the intercostal nerve. The fascicles are just brought together. There should not be tight closure. Otherwise, there might be buckling of the fascicles. So 2 sutures, 6 and 12, and rest will be the gluing. You can see the intercostal fascicles, and here the musculocutaneous. So this part will be augmented with another layer of glue. This is the splint and weld technique. This can be used in other thin nerves also for the purpose of coaptation. Now coming to the teres major approach in tricep. This is a little modification to the method which was initially described by Somsen. I have tried to make it as simple as possible because it becomes little difficult in complex situations where there has been injury to the upper end of humerus or clavicle, lateral end, to reach to the radial nerve, that is the triangular space. So with this technique, what we do is that we first reach to the teres major. This incision will show, this marking will show the inferior border of teres major. So this incision, the donor nerve will be above to the that is axillary nerve will be above to the teres major, and recipient nerve will be below to the teres major. So we'll see it now. The first first step in this is we reach to the teres major. So this is the teres major, lower tendinous portion of the teres major. It will be divided. This approach is used in partial injuries, C5, C6. This is the long head trapeze branch. The division will reduce the adduction force, and at the same time it will increase the length of the reach of the long head trapeze branch. Axillary now we will look for the anterior and posterior divisions. This is the posterior, this is the anterior division. We will divide the anterior division, and then we will do this is the long head trapeze branch. So we can good length proximally of the long head trapeze branch, and then we can do the coaptation. So this I have published as recently. This article was published just 3-4 months back, The teres major first approach for deltoid reinnervation in brachial plexus injuries with shoulder fracture dislocation. Just a moment. There is one more. How to reach to the I'll read. Okay. I think compression neuropathies in the upper limb. Most common are the carpal tunnel, cubital tunnel, post-interosseous syndrome, and Gouin's canal syndrome for the ulnar nerve compression. Carpal cubital tunnel syndrome. Problem. The videos are not running. No problem. Wait. Patient will generally have pain, numbness in the ulnar distribution. Why? It is problem. I can turn this that side. Because
Do you have these videos as separate files sir, on your pen, right?
I went to the file, but it is not. It is running here, but not on the screen. It is running here.
Because sometimes they don't run in PowerPoint, but as a separate file. If you
Without slideshow.
उसको मिरर कर दे
Dr. Bhandari sir, till the time they are doing this,
Yeah.
can I ask any doubts, any queries? Please ask Dr. Bhandari now.
चल क्या राइट नीचे विंडोज
On the videos which he has already shown.
Any questions, please?
So what was that suture, sir? That was solvable monofilament.
Yeah, that is
What is that suture?
that is monocrane.
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 Okay, instead of vital, it is monocrane.
It is monocrane. Vitally generally we give for the muscles. Because it is a multi-filament suture, and it has got more chances of infection also. But being muscle tissue is quite vascular, so infection is well taken care of. So the good suture for the muscle approximation will always be back. It doesn't cut through. Monocrane is a monofilament. If we put through the muscles, it might cut through. Why we don't use Vicryl for the subcutaneous closure is, again, being a polyfilament, chances of infection might be more. Monofilament is a monofilament suture.
Right.
So chances of infection become very less. Oh.
Sir, in overlimb transfer you said
Mhm.
there is no need to look specifically for the contraphysical for FCU.
Yes. I think
We
we just
shows-
finished
yeah,
just
then
5-10
we-
minutes.
Yes.
So it's self-explanatory. You must see it. You might have read in the books also, cubital tunnel. this is the doctor himself is the patient. He is explaining what problem he is facing. He is a physician. This is the incision for bridging the cubital tunnel. These days it is done by endoscopic methods also. The incision. Basically, we have to divide the fascia, thick fascia, which is compressing the nerve, and we have to transpose the nerve anteriorly so that it doesn't go again into the tunnel where it's likely to get compressed again. So the first step is to divide the thick fascia, which is compressing the nerve, proximal ulnar nerve, and we'll go to the distal ulnar nerve. This is the distal part. So we have released it. Here is the nerve which is entering into the two heads of flexor carpi ulnaris. Again, there might be some compression at this side, so we decompress that. Careful to preserve this branch, the branch to ulnaris, flexor carpi ulnaris. So, dividing the nerve, the adhesions. Now we can see the nerve is thickened, inflamed because of the chronic friction. Now, if we just complete the procedure here, what happens? Just see. Once the patient flexes, the nerve comes anteriorly, but again when the elbow is extended, it goes into this, in the same tunnel. So our aim is to keep it forward, to keep it in anterior position. So we make two flaps and then bring the nerve in a muscular tunnel. This is to avoid the recurrence. So, it doesn't slide now into the tunnel. So, this is anti-transposition. Next, please. Hello. Next. It's not running. Now we'll go to the post-interosseous nerve syndrome. Yeah. Yes. The patient is a lady, middle-aged lady, and she has got difficulty in extending the MP joints. MP joint. Wrist extension will be there because it is supplied by the branches from radial nerve which come more proximally to the post-interosseous nerve. The main problem is in the extension of fingers at MP joint due to and of course the thumb also, EPL, because these all come from the post-interosseous nerve. So this is how the decompression of the post-interosseous nerve is done. In this case, we found something unusual, which was the cause of compression of the nerve. The dissection is just below the elbow. So here we see something. The first aim is to isolate the radial nerve. Is division into three: post-interosseous, sensory branch, and in between there is a small nerve, extensor carpi radialis branch, which supplies the wrist extension. All this dissection should preferably be done under tourniquet control to get a good hemostatic field. The post-interosseous. The post-interosseous now enters into the supinator. So it has been released. Here it is entering into supinator. Then it will give branches to the extensors of the fingers and the thumb. We'll go proximally to look for the radial nerve. This is the superficial sensory branch of the radial nerve. Main radial nerve. This is the branch to the extensor carpi radialis brevis. This one. Now, can anybody tell what is this? What is this structure? Anyone? It is not a normal tissue. Looks like fatty tissue. Yes. So, if you read about the knot compression syndromes, you'll find many times lipomas, small other tumors, they are also causing the problem. So these were the lipoma. The extensor carpi radialis branch, post-interosseous and sensory branch of radial nerve. Now, just one more, that is carpal tunnel syndrome. This one. Yeah. This short video, you can see yourself. Many of you have done also the release of carpal tunnel. One should this is the incision which is given. We should, idea of giving incision here is to avoid the damage to the sensory branch. So again it is done under tourniquet control. Here is the nerve, median nerve. In this case it is swollen up and it has some adhesions also because of chronic friction injury. We divide here is abnormal muscle. We divide it. Palmaris brevis. Now we come to the flexor retinaculum. The nerve passes under the flexor retinaculum and it gives first the thinner branch and then branches to the lateral side of the fingers. So this is how the carpal tunnel release is done.
So what was it horizontal line? So what was the line? Why was it put?
That is called Kaplan's line, but I think only one should remain little medial. The vertical incision where we are giving, one should remain little medial so that we avoid damage to the palmar cutaneous branch. That is the only reason for drawing those lines and all. One should remain medial, then you save the cutaneous branch. And second precautions taken is whenever you are doing blind cutting of the flexor retinaculum, we should avoid damage to the thinner branch. It should be under view. It is always better to give bigger incision than doing a keyhole surgery. That should be the aim, because morbidity will be significant if you just do blind cutting of the ligament and cause damage to the thinner branch. And there are many variations also. It is not that the nerve passes under the ligament, then it divides into branches. Many times these branches, the thinner origin, the origin of thinner nerve is quite proximal also. Quite proximal, and sometimes transligamentous also. So these things have to be kept in mind. So old saying is that bigger surgeons, they give bigger incisions. I think there is some logic for that. So in carpal tunnel release, at times you will find that the surgeons have done the release, but the patient is still having symptoms. The reason is they wanted to show that they can get away with a small incision. It is better to do because the incision heal from side to side, not from up and down. So, and the incision on the palm side, it heals very beautifully. If you see after 2-3 years, the scar will hardly be seen. So, release should be good whenever you are handling such cases, carpal tunnel. Now, any questions on our aim basically is on brachial plexus. This workshop is on brachial plexus. So, I showed you some video just to generate interest and to give you some insight what we are going to do today. So, if you have got any questions, you are most welcome. I think, yeah.
Good morning, sir. I'm Dr. Anshu from Plastic Surgery. Sir, I have a few questions. The first question is regarding a brachial plexus injury. So, I wish to know the role, is there a role of identifying the FCO fascicle of ulnar nerve in a pan-brachial plexus injury with the recovered hand function?
Your question is, in pan-brachial plexus injury, is there any role of
Identifying the FCO fascicle of ulnar nerve.
what is the idea of that? In pan-brachial plexus injury, ulnar nerve is dead. So it rules out.
Sir, perhaps she wanted to know
I
about the
wanted to know,
overland.
Overland will never be, it will never be used in pan-brachial. This is only for C5, C6
Sir,
injuries.
if we have a C5, C6, C7 injury, in that, is there a specific role of identifying the FCO fascicle? Because
Yeah, now we are on the right track.
whatever I have seen,
Her question is,
I will tell you, sir, it is not for pan-brachial.
yeah.
It is for, you said that you have modified it. Instead of identifying FCU, you take any one.
Yeah. Now I'll tell you the reason.
Let him answer.
This overland transfer, no, there have been some big developments in brachial plexus surgery. You know, before 1960, these patients were not done. In 1970s, then came microsurgical. Lot of credit goes to Narakas and to the Milesi and all who introduced the nerve graft. So lot of development has taken from 1970 till 2000. After not 2000, I'll say till 2003 or 4. In last 22 years, again we are in the same place. There has been hardly any major breakthrough in last 20 years. So major breakthrough was the period between 1970 to early 2000. I'll tell you why the reason. Milesi introduced grafts. Before that, there was no concept of putting the nerve grafts. He said that if long gaps are there, they can be bridged with the sural nerve graft, and it works. Then Naraka, he introduced the nerve transfer, which we do today very often. Before that, the concept was if traction injury is there, if the roots are ruptured and all, just try to bring them together with big sutures. It never used to work. Now, coming to the Oberlin procedure. Oberlin procedure was described in 1994 by Christopher Oberlin, and he published his paper in Journal of Hand Surgery, American volume, use of ulnar nerve fascicle in restoration of biceps function, a report of 4 cases. So only 4 cases, and that has been a major landmark. Whatever result we get good results today in elbow flexion. It is because of this understanding that if you take a fascicle from ulnar nerve and just transfer it to the biceps branch, there is early return and very safe procedure and gives good results, almost more than 90% success rate. Before that, people used to do various nerve transfer or nerve grafting and all, or muscle tendon transfers to restoring elbow flexion. Results were poor. So when this transfer was described by Oberlin, he says, use the fascicle of the ulnar nerve, which supplies the flexor carpi ulnaris, ulnar flexion. Why so? Because the other flexor is intact, median or innervated. That is flexor carpi radialis. So there won't be any problem in flexing the wrist if you just sacrifice one. Number 2, if you take other fascicle, it is possible there might be problem in the intrinsic function, because ulnar nerve is basically having the good, it produces good grip strength. So there might be weakness in the hand grip. So these were the only concern. For that he said, use the flexor carpi ulnaris branch. Now, article was published in 1994, and after that there have been many publications. It got so it was so good method, and it doesn't take much time also. It is very quickly done procedure and with good results. So after that many articles came, because people were very much impressed with this kind of reconstruction. Many, and each articles they insisted that we should use the flexor carpi ulnaris fascicle for the biceps branch. This was followed till 2009. There are many publications written in the textbook also. What I was working in the RR hospital, and I did many Oberlin procedure. Then what I found was that it is not like that. If you take one fascicle which is close to the biceps branch, just transfer it, you get result, and there is no any weakness also. So I was very happy. I found something different from what what has been described since last more than a decade. So I published first in the Indian Journal of Neurotrauma. Naturally, it is our journal, so it was no problem in getting it published. Then I thought, why not to publish in the international journal, so that it is accepted by the all. So I sent it to the that time one journal was in my mind, that is World Journal of Neurosurgery. I sent it to that for publication. There were 25 observations by the reviewers, and they said not acceptable for publication. One of the very important reviewers' remark was that you people are from, the author is from a third world country where there is no access to the nerve stimulator, and they are giving the wrong idea. So article was, but those 20-25 the remarks, they helped me a lot to refine my article. I knew now where I am lacking. I made the paper again, read it 100 times, and then I sent it to the same journal where in 1994 Oberlin has published his paper, and it was published I think in 2011 in the same journal, in which I said that there is no need to do nerve stimulation of the, you use the nerve stimulation, no doubt, you want to see whether the ulnar nerve is good or median nerve is good, but there is no need to do too much of dissection of the ulnar nerve just to identify one, because if you do too much of isolation, you will jeopardize the blood supply of the fascicles. They lead to fibrosis. So in that bargain, you lose the function of the nerve. Just take one fascicle, which is close to the biceps branch, and which requires the minimal interfascicle, because at this level there is so much of intermingling of the fascicles. They cross. There is no such fascicle which is going direct from here to here. There is so much of crossover. So it was published, it was accepted, and in 2016 we had a World Congress in Brachial Plexus and Peripheral Nerve Surgery. There I happened to meet and Mr. Oberlin, and he also published his paper, 20 years of experience in Oberlin procedure, and he agreed that there is no such need. Now I don't think anybody is doing such kind of following that. What I want to convey is that whatever is written by the legends, we keep on following blindly. It may not be correct also. Your question is answered.
You do electrophysiological testing, right?
Always.
Always. That means because there is a possibility of some sensory physical coming while you are identifying.
Ulnar is basically a motor nerve. It has got less sensory fascicle, unlike median nerve. That's why ulnar nerve is given priority, median not. Median nerve, if you take fascicle, it is likely that there might be some sensory problems. The patient keep on complaining, I am having tingling, I am having lack of hyposthesia, burning, all these things, which is generally not there with the ulnar nerve. So ulnar nerve is less pardonable. That's why you use ulnar nerve. Okay? Yeah.
So do you always combine it with median?
I generally use combine, but I use nerve stimulation whenever I do brachial plexus. All cases are not same. It depends on the amount of trauma. Okay, I explore. Then if I tape both the median and ulnar nerves, stimulate them. Sometimes in C5, C6, C7 injury, or even C8 also, we find that one of the nerve is not very good. So we take, it is possible median nerve may be better than ulnar nerve. So we take a fascicle of median nerve. That is the role of stimulator.
That was actually my second
Yes.
question.
That is the role of stimulator. But in classic C5, C6 injuries, where you have got very good hand grip, very good wrist and finger extension, very good triceps, ulnar will always be good in condition. Then you can either do ulnar to biceps, or you can combine the ulnar and, because you always want to be safe, so ulnar and median to biceps brachialis.
So, sir, in such cases, are you completely transferring the nerves to biceps and brachialis both, or do you do only one?
Generally in classic C5, C6, this is also little, everybody doesn't follow the same. There have been many articles also whether we should do one fascicle, one transfer, or whether we should do two transfers. There have been many papers, but most of the workers, they believe that if we do the two nerve transfer, we are safer. The reason is, suppose one anastomosis breaks down, other is there to work. I think that is the only concern. But if you do ulnar to biceps, nothing happens. it will walk.
Both
You know?
are practically remaining elbow flexion.
Yeah, both are for elbow flexion. Yeah.
Any more questions?
Yeah, please.
So your excellent work is known to one and all. We have been doing this work for the last few years, but the results are not as encouraging as yours, sir. So we came to know there are some discrepancies, faults are there, the suturings and all may be the culprit. My sir, question is basically, what is your timing when you decide? Because we find in a major of cases the muscles are atrophied. So does that play a role in the outcome? What is your timing after the injury when you decide when to operate? And second, do you use the magnification loop right from the skin incision and later?
Question is that when should we operate? The brachial plexus injuries, all cases are not like acute appendicitis or perforated duodenal ulcer like that. We follow the same procedure. Here we have to tailor-make the procedures. If it is C5-C6 injury, we try to, and root avulsions are there, C5-C6, we do multiple nerve transfer, which I have just shown. If it is total palsy, we don't have any donor nerve. We have to depend on extra plexal donors like intercostals, phrenics, contralateral C7, like that. So, when should we do the surgery? In total palsy, we know that the patient is not going to recover. He has got totally flayed, insensate limb. It is not going to recover. So the question is whether when should we do? If the patient doesn't have other injuries, which is very, very rare, because these are all polytrauma victims. Most of the time they will come to the under your care, head injuries, limb fractures. They take priority over the brachial plexus reconstruction. The reason is other injuries are drawing attention. Many times brachial plexus injuries missed also in emergency situations. We come to know only when the patient has recovered his insenses and he says, I am unable to move. At the time of discharge, we come to know about the limb paralysis. So generally you will find that 4-6 weeks or 2 months, 3 months are generally in the management of the acute traumatic situation. Then we realize limb is not working and the patient is referred or operated. But if the patient doesn't have other injuries, which generally in total palsy you will find 1 out of 10 cases. In such cases, the surgery should be done after 4 to 6 weeks, not immediate. Now question is why not? If other injuries are not there and we are certain that it is not going to recover, then why to wait for 4 to 6 weeks? Why not to do immediate? Remember, it is a polytrauma case. Some injuries are obvious, some are occult. We do not know what is the injury to the other organs. He might have internal trauma to the organs, he might have lung contusions, and the surgery which we are going to do is under general anesthesia, long surgery. So we should not subject a patient to that much of risk by doing an early surgery. This is another reason. The another reason is the if you do MRI, firstly, MRI should not be done in the immediate scenario. MRI should be done after 4 to 6 weeks. Anyone can explain? Can you explain?
Yes, sir. In the initial period after injury, there is a lot of tissue edema.
Yes.
The brachial plexus and the severe nerves and the structures. So it is difficult on an MRI to comment about which part of the brachial plexus is actually injured, and also to comment upon the occurrence of pseudo
Yes.
and all.
So thank you. If you happen to see the MRI which has been done either at the time of admission in ICU or just after 2-3 days, you compare this MRI to the MRI of the same patient done after 4 to 6 weeks, you realize the difference. characteristic feature of root avulsion injury, radiological feature, is the pseudomeningocele. It takes around 3 to 4 weeks time to develop. It will not be seen usually in the immediate picture. So MRI should be done after 4 weeks. Electrophysiology should be done after 4 weeks, not immediately. That report will not give any idea. So wait for 4 weeks, then do MRI. Pseudomeningoceles are there. Now we know which roots are ruptured, which roots are avulsed. Accordingly, you can make your plan. If it is ruptured, we might think of doing grafting. If they are avulsed, just go ahead with the nerve transfer procedure. So this is the idea of waiting for 4 to 6 weeks if other injuries are not there. Another reason I have told you, by this time the patient is stable, up and about. He can tolerate the long-standing surgery, long-standing anesthesia. So 4 to 6 weeks should be there in total palsy. Partial injuries, we should wait for around 2.5 to 3 months. There is nothing like 6 months, 9 months. That rule is no longer. It was there in the old books, old concept, because that time MRI was not there. Most of the patients were not subjected to MRI. This has come in last 5-10 years only. Now MRI gives us clear picture that it is ruptured from here. It is pseudomeningocele is there. If pseudomeningoceles are there, more or less we are certain that roots are avulsed. Then what is the fun of waiting for 6 months, 4 months, 5 months? So this education has to be there. Yeah.
For partial injury, why we should wait for 2.5 to 3 months?
Yeah. Total palsy, there is no chance of recovery. They have to be like that until unless they are operated. Partial injury, there is some chance of recovery. That's why we wait. Okay? So that is the reason.
How do you prevent the glue going over the cutting zones?
Just bring the two edges together.
Still there is a chance some
Nothing happens.
nothing.
Nothing happens because this glue will remain for some time after it is absorbed. The glue is not for fixation purposes. That it is a kind of bond between the two nerves. It is not like that. It forms a kind of chamber. We can call it as
My
a
question is
reconstruction chamber. Nothing happens.
will it get down over the cut ends?
That will be absorbed in few days time. Though I have not, and nobody might have, until unless you do the experiments in the rats and all, you put the glue and open after 6 days, 5 days, 10 days and see the situation. Again it will be difficult to access, but I think within a week the glue will not be there. By the time there some coagulum have formed, some blood has formed, clots have formed, some tissue have overgrown in that area which is keeping the nerve ends together, and sutures are also there. So even if it goes in between the nerve ends, nothing happens. It dissolves, it absorbs. Yeah.
I think using phrenic as well.
Phrenic should be rarely used. Phrenic is a vital nerve. It should not be sacrificed unnecessarily in the young people, and it should be used only when nothing is available. Nothing. Intercostal nerves are not available because the rib fractures are there, multiple. Chest tube has been placed. Okay, and in that situation probably we might think of, and especially when the injury happens in the left side. The left side lung has little to contribute. Not little, it has less to contribute in total vital capacity of both the lungs, because left lobe has got 2 lobes and right has got 3 lobes. So left side we can get away, but on the right side should only be done when no other donor nerves are available. It should not be used indiscriminately. You know, again here I want to point out that whenever we discuss about the rehabilitation of this patient, more of emphasis is given to the elbow. We say that even you read the books and all, they say the best donor should be given to. Tell me, now you people tell me, which is the priority, shoulder or the elbow? If we have got only one now available, donor now, which function will try to achieve? All of you agree with that? Why? Why not shoulder? No, a total brachial plexus patient will never be able to eat with that hand, whatever we do. With the kind of reconstruction available today, we can only make his life better, but it will not be possible to just like other hand, never. We can get some hook grip, he can lift the things with that hand, he can drink water also with a glass after doing some secondary reconstruction, but it will not be single digit movement independently, he will not be able to do. So now the question comes, which should be addressed if we have got only one function is to be achieved? Again, you adhere to the elbow or you want to change?
Shoulder should be stabilized. Shoulder.
Why shoulder?
That's what we want to know, sir.
Yeah.
Is there any order of?
Again, it is written in the books, and if you happen to attend the lectures of the pioneers who are doing this surgery, they will always say the best donor should go to the elbow. Means spinal accessory with nerve graft to the musculocutaneous. If only spinal accessory is available. And we'll do something for shoulder. That is second stage shoulder trapezius transfer. But this trapezius transfer will not be very good. The reason is the nerve has already been utilized. So it will be weak. And it will not be possible if there have been fractures in the lateral end of clavicle and plate is there. We can't do the trapezius transfer also. Or there have been fractures in the upper end of humerus. Or some plating has been done in the humerus in the upper end. We can't do the trapezius transfer because it has to be fixed in the upper end of humerus with screws. So that is ruled out. What I think is, and what I follow is, that if only we have to give best donor, it should be for the shoulder. Foundation. We will not achieve much. The patient will not achieve much if he just gets some elbow flexion, but shoulder is going down. Elbow is just for elbow flexion. You know, why these people have to hang their arm? Because shoulder is unstable.
They put the sling there.
They have to wear the sling. It is required. So if we can just get some abduction, maybe 20 degree like that, if we can make the shoulder stable, immaterial to the elbow and the finger, his life will be better. He can wear the dress, local hygiene is maintained. Otherwise, if you happen to see these patients in the OPD total palsy, the arm is just stuck to the chest, so much of sweating, sometimes infection. But if you can give just abduction 10, 15, 20 degree, and if you can stabilize the shoulder, the life becomes better. They can go outside, they can socialize. By giving just some elbow, but no shoulder, subluxated, we are not achieving much. That is my thinking. So I give priority to the shoulder, not to the elbow in total palsy.
So first shoulder, then sir, elbow. Or
Yes.
Then wrist.
Fingers are always required. Even if the elbow flexion is not there, shoulder is good, he can lift some bucket and all. But not possible in fingers. The reason is total palsy we have not achieved that much. In total palsy we try to reanimate the shoulder and the elbow. And for the fingers, many types of reconstruction, doing free functioning muscle transfer and all. Many things are available. Tendon transfer will also not be available because tendons are not available. They themselves are paralyzed in total palsy. So what I do in total palsy is that in first stage I do the nerve transfer for the shoulder and for the elbow, or nerve grafting if some route is available. Then once they have restored a good biceps, that will take minimum 2 years. Then this biceps is lengthened with a fascia lata tube, fascia lata graft. Proximally, it is attached to the biceps tendon, which is detached from its insertion, and distally it will be fixed to the flexor digitorum profundus and flexor pollicis longus tendons, just to achieve a hook grip. And wrist, which is flail, it is orthodized. And because the thumb is an adduction deformity, we put a bone block between the first and second metacarpals. So this is the way I rehabilitate these patients with total palsy. Yeah.
So apart from the brachial plexus, this question is about the cubital tunnel syndrome. My question is about the cubital tunnel syndrome and release video that you showed, sir. When we do the anterior transposition of nerve, in that the muscle sleeve that we make to accommodate the anteriorly transposed nerve, down the line, does it cause any fibrosis and recurrence of the syndrome?
Fibrosis because of the
sleeve, sir.
Because of this
Because of the muscle
transposition.
Because of the muscle sleeve.
Because of the transposition.
Yes.
I don't think so. I don't think so. Because we are putting the nerve where there has not been any fibrosis at all. It's a native healthy muscle. And whenever you are doing transposition also, the nerve should glide. It should not get compressed. It will again become a tunnel. So that should be done. Always I think the transposition should be done, especially in the long standing cases. Okay.
So after this procedures, so what is your role and how you train the patient and the relatives to take care during the rehabilitation at home? Do you suggest some transcutaneous stimulators and all?
After surgery for 4 weeks, the arm is strapped to the chest. Earlier I used to put this elastoplast, very tight, very rigid immobilization,
For shoulder
and many times fixed also to the very difficult to remove. Later realized there is no need to do such immobilization. For last almost 10 years now, I am just using the crepe bandage, 2 crepe bandages, just to put the arm, to immobilize it onto the chest. 1 month. In between, of course, we have to remove the sutures and all again. After 1 month, this immobilization is stopped. Then the patient does some pendulum kind of exercises, so that when we remove after 1 month, we'll find that the shoulder is stuck, the elbow is also in flexion deformity, because it has been kept for weeks like that.
Yes.
So in such cases, I'm sorry. In such cases, I advise them for 2 months the stretching kind of exercises. They do themselves. I never hand over them to a physiotherapist. In fact, now these days, I write onto the discharge some slip, the remarks, post-op. Please do not consult any physiotherapist without my consultation, because they have hardly any idea. Now, I have done the procedure. he will try to, because he has no idea, they are basically Pahlwans. So he'll try to, forcibly he'll break all the things. You have done the overlaying, gone. So for 2 months after this surgery, 1 month after surgery, for 2 months they do the stretching exercises. After 3 months, they have to do strengthening exercise. They do themselves. I do not hand over to any physiotherapist. They do themselves.
With that they feel engaged and motivated.
Yes. I keep on guiding them.
In our department, sir, they are routinely doing flexor and extensor techniques.
Hmm.
Our residents are here. All physiotherapy, majority of the time they are doing
Yes.
extensors.
That's why I
They
said.
sit with the patient, themselves move, themselves teach the patient.
Yeah. So results do not come only by surgery.
Rehabilitation.
It comes by giving a good post of care. That care is in the hospital. Whenever the dressing is done, I am standing there. Earlier I used to do all dressing myself. No one will touch my patients. These days, now I have got better staff who is with me for almost 9-10 years. They know what I want, they have been trained. But first dressing, which is done after 2 days, means second post-op day, I am standing there always. In spite of knowing that this person can do he is not less than me in doing the dressing. But even then I made a point to stand there whenever he is removing the drain. Because the kind of interest on the recovery of the patient which I will have, the other people will never have. So lot of, I think, time is taken of yours, and after discharge also. Till now I have not given this responsibility to anybody. What exercise they have to do, when to do. They are always in touch with me. In the around 9 to 10:30 p.m. I get call from them. I am available to them, free of cost. I keep on guiding them. They ask funny questions. What should be taken? Can I ride the bike again? Can I take non-veg? Can I drink alcohol? Sometimes it pinches you also. What I am doing, they are all illiterate persons, most of them. But I have to satisfy their queries. So it is not only the surgical part, it is also, you have to generate, these are depressed patients. They have lost their job. They are not going to the society. They have lost their friends. They think that everything has come to stand still. So, only the doctor who is treating them, he can keep them going. So I keep on guiding them that you have to do this exercise. I attend their call whenever. Like just now I got a call from one of the patient. Once I finish here, my first duty will be to redial his number. So you have to generate interest in the patient. Don't worry, you will be alright. Do exercise. Otherwise they will not do. They will end up in various kind of deformities. And also, of course, you have to show them the patients who have recovered. You have to share the numbers of the patient to them who have recovered. So there is a link. So it motivates them. It gives a positive thinking.
In our hospital, we have made a WhatsApp group.
Hmm?
WhatsApp group of the patients
Hmm.
at the same time, the brachial plexus.
Hmm.
They keep on talking to them.
Yes.
I have recovered over 2 months. Don't worry, you will recover over the period of time.
They should not be left in isolation. That is very important. They should remain in touch with the other patients. That's a kind of a stimulus. And this result do not come in 7-8 months or 5 months. They take years. So till that time you have to follow them. It takes lot of your energy, of your time. I think workshop is also there.
Yes.
Madam She said that you have to finish off in time.
Here's a short lamplight.
Okay. Any questions? Just one more question. Anybody? Any question? And you can ask. I think residents are there and they have not asked any questions. You just ask any questions. No?
Then I will ask.
Yeah.
How you developed interest in this subspecialty? This is the first question.
Now, the answer to this I'll share with Dr. Prabhat Srivastav, because being the same specialty, he knows my teachers also and me also. When I was doing my MCH, a patient came with brachial plexus injury. Though those days, very less number of, it is most motorcycle accidents. Those days motorcycles were not there. They were there but not that common. So one patient came with brachial plexus injury, soldier, and we all were looking at him how to manage him now. I was doing residency first year, so he said, why can't we? There were two surgeons that time who were doing brachial plexus surgery. One was from Chennai and other was from Bombay. Chennai, I said, not Coimbatore. Okay, so he took the name of the surgeon from Chennai, who was much senior to him. He said, we'll try to take his opinion if required, because I have also spent some time in Chennai in that unit. Stanley was the very good in hand surgery. So I would like to either send the patient to, I have spent time and they are doing good hand surgery and they have done brachial plexus also. So I will refer this patient or I will take his opinion how to manage. That time I thought, what is such great in this surgery? Why can't everybody do it? So ultimately then he was the head of department also, so of the surgical discipline. So he gave this topic, exploration like that in brachial plexus injuries, to one of the MS student who was, he happened to be his guide. And that's why it started. We went to the dissection hall, cadavers in Armed Forces Medical College, Pune. We started doing dissections. Lot of difficulties, cadaver dissection entirely different than doing on the patients. We encountered so many problems, but ultimately I think that was the humble beginning. And it generated to me, it looked to me very, very, an area which is still remains, which is still unexplored. So I thought, why not do? And secondly, I was lucky enough. The teacher had trust on me. They pushed me rather. You do this. You have to make your interest in this. Probably they might have saw something in me. And I started doing all these brachial. First, initially I used to do with the neurosurgeons also. I used to do with the senior plastic surgeons also. But ultimately I took over and I started presenting in various conferences and people started appreciating and all. It's more than 2.5 decades now. So at the moment I am not doing any other surgery except brachial plexus. I am sitting in one of the corner of the country, but I keep myself occupied only with this kind of surgery. Most of the patients which I have not shown, Prabhat might have expected, I will show soldiers doing up and down. So, and earlier people used to think that in armed forces we have got very good physiotherapy backup, no doubt in that. And the soldiers have got very good muscles. We just put some nerve and they will start moving. They are strong people. But these days I am available to all. Most of them are poor patients.
Nerve supply is the same irrespective of him being received.
No, but that was one one senior surgeon came from. He came to inspect RR hospital. He came as a DNB inspector. from Andhra. Now you'll know it,
Yeah,
from Hyderabad.
I know.
So he came there and first he said he went to the ward, saw the patient. Then he said, I want to see your physiotherapy department. How you are getting those results. I want to see that. There is something in your physiotherapists and your department which helps in the rehabilitation of this person. Of course, we went there, but there was nothing, just routine department. These days, as I said, I do not hand over to the physiotherapist because of the reasons, but I will not recommend it also that you should not. If you have got a good physiotherapy department, you have got the good physiotherapists who are taking keen interest as much as you are taking in those patients, then you can hand over to them. Otherwise, like me, you'll have to spend a lot of time. Yeah.
Sorry, one more. So did you find any difference after using glue? Initially you must have been using just sutures. Now minimizing the sutures and using glue, have the results improved significantly?
Good question. I think all these I have published. The Oberlin also, where nerve stimulator I said, that is also published. Entire article you will find. If you just happen to say bifascicular nerve transfer or Oberlin or ulnar to median of fascicle, type my name PS Bhandari, you will find this article. This glue also I published long back, and I did a project also, 2 years project, whether the glue is better or synthetic suture is better. So in that I have highlighted, the article published was based on that project only. And what happens if you use too much of sutures? There might be some mismatching also between the donor and recipient nerves. There might be buckling also. If your tension is much, if tension is less, the nerve may not come very closer. If tension is too, there may be buckling. The axons will get misdirected. They will not go into the distal end, they will be just going sideways. With the glue, you just put 1 or 2 sutures, you are allowing the nerve to regenerate physiologically. That is chemotaxis. The motor axons will go distally to the motor axons, sensory axons will go distally to the sensory axons. So the results are better.
If at all we don't put the glue, sir, I think if at all we don't put the glue, is there any disadvantage?
Again, I will say glue doesn't create miracles.
Already they are coated.
Yeah. If you have put 2 sutures and your immobilization is good,
then I don't think there is.
yeah. But I think in the beginning one should use 1 or 2 sutures along with glue. But as your experience increases, you come to know that how to adjust the tension between the 2 ends. Then one can get away also. But I think 1 or 2 sutures plus glue is better. Though it increases the cost by 15,000.
It is the confidence to the surgeon. It is confidence to the surgeon.
Confidence?
To the surgeon that
Yeah.
that is more important.
I was about to mention that. Many times, we follow the same thing because we think that if you don't follow, result may not come also. It's a pseudo confidence. So that might be another reason also. But as I said, glue will not cause miracles. But in splint and weld technique, in intercostal to musculocutaneous, I think what I find is it creates miracles. Because if you pass 9-0 suture through the half of the nerve, it's gone. And secondly, we do not know where to put in the musculocutaneous. Musculocutaneous is a big nerve, and these are just thread-like. So you just hang them, we do not know. But if you glue them, they will migrate.
Single unit.
So here it is absolutely required. Ma'am, I think we are getting late.
So thank you, and we heard actually, and we saw how Stalwart is doing surgery and actually authority in brachial plexus, and we saw how clean and artistic surgery he has done it is bloodless, sir, and it is really great. And how do you put the tourniquet for how long? We can see that in the we can demonstrate in cadaveric lab or cadaveric section also. So just we can have a small brief introduction of everybody, and when we move to the for the lab title. So we can start.
I'm Dr. Shweta Kedia from AIMS Delhi, neurosurgeon.
Ma'am, Dr. Sabita. She's
It's an anatomy department.
she's head actually and anatomy department. Yeah.
I'm Dr. Srilekha, first year DRMD resident from Local and Hospital Labs.
Dr. Luchna, DRMD first year from plastic surgery. Dr. Preta Yadav, first year DRMD plastic surgery.
Dr. Anand Singh, second year resident from Lab.
Speak loud, please.
Dr. Amlan Mishra, first year DRMB training from plastic surgery.
Dr. Puneet, consultant neurosurgeon in Brachial Hospital.
Good morning everyone. Myself plastic resident from plastic surgery program. Dr. Vishu Rathi, neurosurgery RM, second year.
Yeah, Abhishek.
Good morning, I'm Dr. Mayak, MCA second year SR from neurosurgery.
I'm Dr. Deepak Gupta, second year senior resident in surgery at Hospital.
Ahmed Masood Aziz, post MCH from JB
Dr. Shankar, consultant neurosurgeon, GBS Global. I'm Wajid Nazir, professor neurosurgery, GBS.
Dr. Vikrandam, consultant neurosurgery, Manipal Hospital.
I am Dr. GD Singhal, professor neurosurgery, GBS Hospital.
I am Ved Prakash Moria, additional professor neurosurgery from SGPGLMS Lucknow.
I am Meher Kalsi, second year neurosurgery resident from RSM Hospital.
I am Dr. Yogesh Agarwal, consultant neurosurgery, Narayana Hospital, Jaipur.
Dr. Anshu Tiwari, specialist plastic surgeon, Local and Hospital.
Dr. Aditya Ashwin, neurosurgeon from Rana.
Dr. Priyadashni, ex-senior resident from plastic surgery.
Good morning everyone. Dr. Raman, assistant professor, ESIC.
Good morning everyone. Dr. Abhishek Shah, neurosurgeon from the last lecture.
I am Dr. Ankit, neurosurgeon.
Dr. Hoshir Garg, MCH resident, neurosurgery, GBS.
Dr. Sairam, neurosurgery, second year resident.
Very nice mix of plastic and neurosurgery.
Exactly.
Anybody, this is a branch which is practiced by neurosurgeons, plastic surgeons, ortho hand surgeons. It is a multi-specialty problem. And here I would like to mention that we try to do this kind of surgery when we begin our career. We are very keen to explore this field, but after some time we give up. That is a known fact. After some time we give up. There are reasons for that. It's a very good, very satisfying branch, let me tell you. And if you are really interested, you can get good name. You'll have command over your specialty. But only thing, it requires lot of understanding, lot of time also.